Hello, everybody. Welcome to Grand Rounds. Excited to have you with us, and excited every time Dr. Coca comes and joins us. His talks are always engaging, and so we're happy to have us talking to us, especially since the last time he spoke to us when the KidneyintelX Renalytics test was sort of a dream in a way. Now we've really been ordering them, and we've been getting results, and it's been changing management. And so I'm sure he'll be talking about that today. You may know that he's the co-founder of Renalytics and was just awarded the 2021 Distinguished Researcher Award from the American Society of Nephrology. Dr. Coca is an associate professor of medicine at the Icahn School of Medicine, the associate chair for clinical and translational research, and the director of clinical research in the Division of Nephrology. Dr. Coca, thank you for joining us.
Well, thank you for having me again, Dr. Weissman. Even if it's over Zoom, it's as we were chatting earlier, it's a great time to update all of you, and I really look forward to this. And as I was mentioning to Dr. Weissman, please put your questions in the chat if you have one that comes up in real time. I'll try to address it in real time. It often is the most apropos time to address it then, rather than all at the end. So let me get this on sharing. Switch this over. Disclosures, I have it's just to tell you, it was such a dead area in nephrology for decades. And these last few years have just seen such an exciting plethora of new data and new therapies for kidney disease. So I'm just really thrilled for the patients with diabetic kidney disease, chronic kidney disease, because there are these opportunities now that we didn't have 5 years ago. And part of my consulting is maybe reflecting that new birth of efforts in this space. Dr. Weissman did mention Renalytics, which I'm a co-founder of, and I'm going to talk about the lead product, KidneyintelX, toward the second half of this talk, because that's really where my research led to actually potentially making an impact on patients with chronic kidney disease. So the motivation for all of this is this: dialysis, end-stage kidney disease, kidney failure continues to grow, and these are the projections for the next decade. So many more people will be living on dialysis, and with the trends in diabetes and obesity, more and more people are going to start dialysis each year. It's about 660,000 people on dialysis currently. The majority of my research in the last 5, 6, 7 years, and the thrust of the commercial efforts have been in the setting of diabetes. And why? Diabetes, the leading cause of kidney failure in the United States. And look at this. Here's the curve for projections of diabetes in the next several decades. That is going to continue to explode and wreak havoc on the kidneys. And look, I'm a nephrologist, I'm a nephrophile. I love the kidneys. I've loved them since medical school when I saw the transporters on the tubules. And I know that's like the Rorschach test for whether you love nephrology or not. But for your patients, think about what's happening in this diabetic milieu. It's not just the kidneys. There's a huge overlap with heart disease, especially heart failure. There's just overlap on spending in that Venn diagram, the Medicare spending. And look at these bar graphs from USRDS, even in early stages 1 to 2 and stage 3. So stage 1 to 2 is gray here, stage 3 is green. Look at that, 2/3 of patients have underlying cardiovascular disease, whether it's heart failure or coronary artery disease. So there's feed forward and crosstalk between the organs, right? So it's not just about the kidneys, it's about overall health and cardiovascular health. We know that when patients reach dialysis, and I just started dialysis service today, 45 plus patients, and I mean, it is depressing. Thank God I don't do this full time. Everyone has so many complications, infections, amputations, calciphylaxis, on and on and on and on of horrific stories. And this graph kind of summarizes the overall picture. Everybody does the fire drill for cancers and gets multiple consultants and scans and and second and third opinions. Survival with diabetes and dialysis is worse than most cancers we see and talk about. So how about that for action? And look, even if you survive on dialysis, this is what I'm alluding to. This is, even if you can, and now the goals are, get them off of in-center dialysis because that's such a time sink. They have to go to the unit. Get them on home dialysis, whether it be peritoneal or home hemo, which that program is growing now. That's still not a way to live. You're still hooked up to a machine. You still need an access. Even peritoneal, you've got the peritoneal catheter, home hemo, you've got a vascular access. You've got disfigurement. You've got the complications that ensue. Here's calciphylaxis, so painful, necrotic lesions. We're seeing less of NSF with these new gadolinium agents, but that has certainly affected enough patients that to cause severe debilitation. Amputations abound in the dialysis unit, and there's just so many other things that come up. And I mean, the list of bacteria and fungus and everything, again, on my list today, today was my first day of service, so it's really hitting me today, again, as I give this talk about why we need to move to the front end, and we can't let these patients forget the dialysis. Everybody says, yeah, they got a machine, they'll just hook them up. It's not the way, and I can't tell you, even as a 20% clinician that I am, then I'd have a room full of dimes. If I had a dime, every time someone told me, why didn't anyone do something sooner about my kidney disease? Why didn't they tell me sooner? I didn't know. And even these were just some cases I pulled out. I had screenshots on my phone. Certainly doesn't encompass all of it, but this was a patient progressing for 5 years, and you can draw that trend line. And a bunch of things were ordered here at the end. I'm going to move my things. GFR 7, and they're doing a glomerulonephritis workup after progressing 5 years. It's too late. Here was a patient crying to me, referred with GFR around 20. I told him, you got to start. He's on peritoneal dialysis now, but I mean, it ruined his life essentially, and he'd been progressing for years. This patient, falling from 2013, GFR, sorry, just cut off here. This is 30, 40, 50, GFR 50, 60 here. They're falling off the cliff, getting bolus with IV fluids for AKI. I mean, this was not AKI. This was rapidly progressive CKD here. But it's not just me being a whiner right now. I mean, nationally, this is the state of what's happening. Only 32% of patients see a nephrologist for more than 12 months prior to starting long-term renal replacement therapy. The rest are referred very late or not at all. And there's the so-called crash landings in the ER where we have to put the catheter in. And then, they're here for a week. They get the transition. They get an AV fistula, hopefully. It's not the way to do it. And how can we improve outcomes? Well, the problem is up front, none of this is symptomatic. No one comes to you and says, doc, check my kidneys. I feel like my creatinine's up a little. The only thing they're going to have pain about is kidney stones, really. And that doesn't necessarily cause CKD. All the symptoms and they're vague symptoms when they do get it at stage 5. It's not like specific to the kidney, but all that's late, and there's nothing up here unless they're nephrotic and they've got, edema and things like that. But that's the minority of patients. Most of it's silent. And look, I love this study. This was Linda Shezik at Duke, who I love just saying her name with all the 4 consonants in a row there. They compared to laboratory-based CKD. So up here, you needed albuminuria because you had GFR above 60 for stage 1 and 2, or stage 3, GFR 30 to 59, all ranges of albuminuria. And the red bars are the amount of the percentage of PCPs that either mention CKD in their note or coded for it, billed for it. You can see it's the vast minority are even having it recognized. And then the green bars are from NHANES, where everybody gets a blood and urine test and they can assess cross-sectionally representative individuals, what their prevalence is. And then they ask people, oh, did you know you had CKD? And look at that. 95+% don't even know they have CKD at these early stages. And what does that mean for actual treatments? You always see these reports, but insufficient numbers controlled in terms of blood pressure and glycemic control, insufficient numbers on RAS inhibitors and statins, and remember that overlap with cardiovascular disease. Yeah, they're not great for dialysis patients, but in CKD, we have the landmark SHARP trial that shows they reduce cardiovascular events in CKD. SGLT2 inhibitors, 10% or less, a bunch of papers keep coming out on underutilization of SGLT2, and we're going to talk about that. And this is what I'm talking about. This is the excitement I was talking about at my disclosure slide, is we are not in this dark era anymore. This was my intern year. I remember how excited I was, and now I laugh at myself because I was stupidly overly enthusiastic, because over the years, I've looked at the classic IDNT and Renal Kaplan-Meier cumulative incidence curves here, and I remember everybody thinking these were the greatest. The ARBs were the greatest for slowing diabetic kidney disease, but what hubris that is! I mean, these are small risk reductions, and I would hate to be a patient on either one of those curves. They're progressing way too much. And I always love asking the fellows or the residents, how much are you slowing down GFR decline when you have a patient on an ARB? And look, and this was max dose ARB, which is in line with the guidelines now. They say max dose. But we know actually in real life, probably 70–80% are not on max dose. But with max dose, you only slow progression by about 1 milliliter per minute per year. So you're not covering them. So it's statistically significant. But we need to get those curves down here or even lower if possible. And by the way, nobody even really talks about that. There was no improvement in mortality in those trials. So along comes the dark era I'm talking about. These are just a handful of the major trials of various agents that were tried for diabetic kidney disease since the IDNT and Renal, and it was all null trials, no effect, some harm in some trials, but largely no effects. And, some of these are very targeted therapies. DKD is a very complex syndrome. It's not a disease. It's not polycystic kidney disease. Mutation, dysfunctional cilia, cyst, blah, 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 or one of these monogenic glomerulonephritis. No, it's complex. It's a syndrome through multiple pathways. I'm not going to take you through all these that lead to the histologic changes in the kidney and then lead to the phenotype of albuminuria and decreased GFR. Here's another slide, again, to just show you how complex this syndrome is, and that a single drug targeting one of these pathways is not going to work. There's too much redundancy in these pathways. And so now this slide shows some of these drugs and how you'll notice it's not just, you're going to see repeated MR antagonists are hitting a lot of these different pathways. SGLT2 inhibitors, here's 1, 2, 3, 4, 5, 6 times. They're hitting multiple things. And that's why you're now starting to see efficacious therapies, because they're not just hitting one pathophysiologic pathway. So any questions so far? I want to pause because I know I go fast. And you guys are good on the volume for me, right? I've got my noise canceling earbuds in, which I started doing recently with the Zooms, which everything good? Let me just hear you say all good if you don't have questions.
Yeah, feel free to type in the chat or just unmute yourself and shout out. I don't see any questions in the chat.
Okay, don't be shy. So SGLT2 inhibitors, it started off as a simple premise, block. Really, they were going for the glucose. It was started off as a diabetes drug. block glucose reuptake in the proximal tubule, put out in the urine. Simplistic concept. Improve glycemic control, lose weight because you're losing calories. But it became a lot more elegant than that. You see, Barry Brenner, the king of nephrology, led that Renal trial, talked about hyperfiltration in the late 70s, early 80s, saying that's what's happening in DKD, and we need to prevent hyperfiltration. You need to reduce interglomerular pressure. And ARBs dilate the efferent arteriole and reduce that. They dilate here, efferent arteriole, reduce interglomerular pressures. It looks like the SGLT2 inhibitors, as they are now blocking sodium glucose reabsorption in the proximal tubule, macula densa senses that, especially that sodium chloride to be specific, it sends adenosine to the afferent arteriole, which constricts the afferent arteriole, which then reduces the inflow and reduces the pressure in the glomerulus. This is the analogy is you can't run your car at 5,000, 6,000 RPM all the time. You will burn out the engine. If you run it at 3,000 RPM, nice cruise control on the highway or whatever, you're gonna have much longer engine life. You can't run the glomeruli at high pressures all the time. You'll burn out. So initially you do reduce the GFR. We'll see those curves in a second, but in the long term, it's good. And now, you know, this is such bedside to bench work that's happened with the SGLT2. It's you know, usually it's bench to bedside, but now that we've seen so many positive trials, and I'll show you the data in a second from the clinical trials, they're going back and learning all these mechanisms, which are above and beyond just the simplistic. It's not only reduction of tubular glomerular feedback and causing decrease in glomerular pressure, it's causing so much improvement at the tubular level, oxygen delivery, energetics, improving erythropoiesis. I mean, the list goes on. And here's just one of the slides showing it's like a wonder drug doing all these things, the losing weight, blood pressure, cellular effects. There's a beautiful article by, well, many investigators now. Milton Packer wrote a beautiful editorial. He's a heart failure expert who's led so many trials, talking about it mimics, you know how caloric restriction prolongs longevity, especially in experimental animals. He thinks that at an individual cell level, it's mimicking caloric restriction. And then it's got, you know, beneficial effects on the heart, on the blood vessels, autonomic activity, everything. It's just, it's really if you could design a drug, it's really got all these pluripotent effects. So CREDENCE, which we'll talk about, which was the trial looking at a robust DKD population, they all had macroalbuminuria, was actually started first, but EMPA-REG and Canvas were the first two to hit the street in terms of results, but they were cardiovascular outcome trials and did kidney outcomes secondarily. But we started to see, remember, these trials were designed not to show efficacy, actually. These are safety trials mandated by the FDA to prove that while you control glycemia, you don't worsen outcomes. They just wanted to show net neutral effects on cardiovascular outcomes and mortality. Why? Because for anyone in my era, Matt and Alfred probably remember, the thiazolidine diones were largely shut down in late 2000s, 2008 or so, because they were a drug we were using all the time, but they increased risk for cardiovascular events. So FDA mandated these CVOT trials. And look, EMPA-REG showed improvement in cardiovascular outcomes. People are like, And then Canvas came out about 6 months after that. Maybe not as robust on some of it, but improved cardiovascular outcomes. Now, early on, I started pounding the table about SGLT2 inhibitors, but my nephrology friends were saying, hold on, Steve. Steve's had Canvas, EMPA-REG, and Declare, I didn't talk about, but similar population. Preserved GFR, low albuminuria. These aren't the patients nephrologists see. There are very few dialysis events. So along came CREDENCE. They all had to have macroalbuminuria, so UACR 300 or more, and the mean GFR was 56, and they had a lot more dialysis events. And one other thing they did in CREDENCE, they all had to be on RAS inhibitor at baseline, 99.9%. So you're adding to that, okay? And this was like the moment it was presented by Vlado Perkovic at the World Congress in Nephrology, I think 2019, showed in this population, remember, IDNT and Renal had about a 15 to 19% risk reduction. Here we had a 30% risk reduction, p-value strongly significant in reducing this composite kidney outcome. And what did it do to GFR slopes? Initially, it caused that decline. Why? You're reducing intraglomerular pressure. Long term, though, you get this crossover. And look, you're slowing progression by a significant amount here, more than a 2 millimeter per year difference, almost 3 milliliters per minute per year difference. And I love this slide that takes projections from the CREDENCE trial, shows that initial dip, the crossover, and how if these trajectories persist, you can gain 15 years additionally off of dialysis, off of that partial imprisonment, off of having a catheter sticking out of you or a big bump in your arm with that AV fistula or AV graft. All those other complications that ensue. Here's the number needed to treat. Pretty good. I mean, I'm way less than 100, which is the typical bogey or par. And look, multiple trials have come out. You get about a 38% reduction in kidney outcomes, consistent effect, get improvement in cardiovascular death. It's a win-win. Remember, it's this milieu, and you're getting 2 for 1. It's not just, and you would expect them to go hand in hand. Here was another meta-analysis. These keep coming out because the trials keep coming out. I mean, look at these. Look at this protection. It's fantastic, and it really is a paradigm shift in how we can treat patients with kidney disease. And the guidelines have all updated. I mean, here's the KDIGO guidelines, SGLT2 inhibitors next to RAS blockade now for most patients. And ADA, gosh, I need to update this slide. Well, let me just take you through this. The 4 pillars, they start with metformin. I'll show you more specifically on the ADA and lifestyle, of course, SGLT2, maximum dose ACE/ARB, and blood pressure control. I probably should swap this one out with finerenone because I'm going to show you that data in a second. Alfred asked a great question about SGLT2 and non-diabetic. So we are seeing that these drugs, again, the way the experts are saying this, that they are either diuretics or systemically, protective cardiovascular kidney protective agents with glucose wasting as a side effect almost. And it's really been surprising to some, I guess, that now trials that have looked at non-diabetic populations in heart failure, we've got the EMPA-REG reduced, we've got, which one was it? The DAPA CHF trial, and then DAPA HF, I guess, and then DAPA CKD, which enrolled 2/3 diabetics, 1/3 non-diabetic, and showed equal effect size reductions in those non-diabetics. So it's remarkable. And then we even have the EMPA-REG trial, which is empagliflozin in HFpEF, which has been one of the greatest enigmas, even more than DKD, of having efficacious therapies and improved heart failure and related complications in EMPA-REG. So I don't have slides on all of that here because I'm focusing on DKD, but EMPA-preserved, EMPA-reduced, the DAPA HF, and the DAPA CKD, 4 large trials that enrolled either a mixture of diabetic and non-diabetic in both heart failure and CKD settings, and showed efficacy in all those groups. It's really remarkable. I mean, these things, the joke is they should be in the drinking water. Maybe they should be. the ADA guidelines, I need to update this 2021, updated. It kind of looks the same, but it broke out heart failure and CKD as separate columns for diabetes, and this is in gold for the CKD now. But basically, the preferable is SGLT2 inhibitor. If not tolerated, then GLP-1 agonist added to first-line therapy with metformin and comprehensive lifestyle. Anyone who knows this ADA guideline knows I truncated about 16 columns down. That's why this thing's cut off, because it was a bunch of different columns and it's so confusing sometimes. So I was just trying to show again where we're headed, and here's the KDIGO, the kidney-specific guidelines, putting them equal to metformin. Guidelines, I want to just say it's to titrate that ACE to maximally tolerated dose and to not stop it once they get a little hyperkalemic. Try to do mitigating agents, whether it's diuretics, bicarb, or these new, we've got Lokelma now, we've got Patirimer. And then I don't have a slide on this, but just this week came out a report and an article in Kidney International Reports showing that I think it was DAPA CKD trial. And also the finerenone trials, which I'm going to talk about in a second. SGLT2 reduced hyperkalemia when combined with any of the RAS inhibitor agents. So, because you're getting more distal sodium delivery, et cetera, you get more potassium exchange. So keep that, because studies have shown patients who have ACE-ARB discontinued have increased risk for cardiovascular events than in advanced CKD. Now, why is there gross underutilization of SGLT2? Well, everybody was talking about these adverse effects for a while, and whether it's the yeast infections in the groin, the euglycemic DKA, amputations. Cana had an initial black box warning, bone fractures, 4 years gangrene, AKI, volume depletion maybe, but UTIs. Let me just take you some of these. I've got to update this slide too. Now there's like 6 trials, but it's showing the same thing. Less AKI in SGLT2 inhibitor trials. So a drug that can cause some volume depletion in the acute. Remember, after 2 weeks, you kind of reach steady state. And B, then it's got that favorable effect on tubular energetics. So that may be the reason for less acute kidney injury. It's funny that if you look at the CREDENCE trial, which was all DKD, if you look at adverse events, all adverse events, they're lower than placebo. How often do you see that, right? Less than placebo. Let's look at some of the specifics. Yes, there is an increased risk for the yeast and genital mycotic infections. In men, especially women, somewhat twofold risk. Other things, UTIs about equal. And euglycemic DKA, yes, 11, hazard ratio 11. But look, 11 out of 2,200 versus 1 out of 2,000. So 0.5% had it. And you just have to make your patients aware. What happens is someone who's in typical DKA is running very high hyperglycemia numbers, right? But now they're dumping that extra glucose into the urine, and they may be going into ketosis, and they don't know it at home because their sugar remains controlled with that SGLT2. UTIs, it really doesn't increase the risk for UTIs. Not in the trials. This was a big market scan database using Optimum, and market scan didn't increase the risk for UTI. Fractures, I don't know why the fractures were even suggested, but no signal for that. Amputations, this was not seen in CREDENCE, and let me show you this slide on the amputations. See, Canvas, they had to put a black box warning because of the risk of amputations, double the risk. CREDENCE, despite having, look at this, much higher risk at baseline because they were a more advanced phenotype, no increased risk of amputation in CREDENCE. So, now that being said, during the protocol, during the trial, they changed the protocol to make sure everyone was doing foot assessments and making sure they don't have peripheral arterial disease. So you still have to do that, I guess. Make sure, because that may have been it. They probably didn't give it to people who had overt, peripheral arterial ulcers or, bad ABIs or something like that. Now, then 4 years gangrene risk came out. FDA put out some warnings. I mean, even New York Post covered it. But, this is the kind of report. These are if you've been following social media for some of these COVID vaccine database dredging of the FARS database, this FDA adverse event reporting system. I mean, so they have 58 cases, but who are you more likely to report? You're going to report on a new drug, right? And they even admit they can't establish causality and confounding by indication. So, look, what I've heard from the experts is, practice proper hygiene. Men and women, just shower daily. Tell your patients to shower daily. If they have a little bit of incontinence, they can use some baby powder or cornstarch. I mean, maybe some diflucan for those that have the problem with the yeast infections. But you don't want to, completely eliminate the possibility of someone deriving the benefit of this treatment just for this risk, which can be mitigated. So, I showed you those complex DKD pathogenesis slides before. This was a simplified version. And, the big push is now with finerenone. You'll be seeing studies coming out. We're discussing at 4 o'clock today in our divisional journal club, the Figaro trial, which are talking about these new non-steroidal MRAs, specifically finerenone, which is not like spironolactone, doesn't cause the gynecomastia that you get with spironolactone or the other androgenic effects, and may have and has more specificity for the mineralocorticoid receptor. And basically, just to summarize, Fidelio was the primary DKD kidney outcome trial. Figaro was the cardiovascular outcome, but they really were enrolling patients with some baseline DKD. Is the bottom line. They just switched the endpoints in the two, and they combined them in this fidelity analysis of 13,000 patients. Here they are, a lot, even with preserved GFR, time you may not be thinking about DKD. And what they showed is that finerenone reduced cardiovascular events, 40% risk reduction, number needed to treat 46. After you've seen the SGLT2 inhibitor trial, you're like, not as good, maybe. But it also improved all the kidney outcomes. Here they are, different definitions, but look at this. We're finally in the position, I almost feel like a cardiologist or oncologist, where we've got multiple things to use now to treat patients, whether they're not able to tolerate SGLT2, et cetera. And here's the specific kidney endpoint. Number needed to treat is 60. It's a little high, but it will bring us into our next theme, because here's the absolute event. So another drug treatment, there's a big argument now. Do you start it early on with the SGLT2? Do you wait and see if they're still progressing? There was only 6% of patients in Figaro and Fidelio that were on SGLT2 inhibitors, so the point estimates were quite large to see if there was synergistic or additive benefits, so it's tough to say. And it really leads me into where my research and now the commercialization efforts have been. This is why now with these multiple new drugs and these costly drugs, they're each about $500 a month, why we need risk stratification. So here's the heat map of KDIGO. The way you put them in the heat map is you measure UACR to select the correct column, A1, A2, A3. But nationally, only about 55 to 60% of patients with diabetes even get annual UACR testing, despite it being in the guidelines and despite it becoming a HEDIS measure now, which drives some reimbursements at the commercial level. But it's important because with starting which cell you start, these are your rough risks of progression to kidney failure based on the color coding. Now, even if you get eGFR and UACR, it's tough to say what's going to happen, because some DKD progresses, they go to albuminuria first and then they progress. Some just progress this way. About 40% of DKD patients don't have significant albuminuria, but they reach kidney failure. And some people have early micro or macroalbuminuria and then they experience regression. And actually there's some regression now of GFR that's coming up in some studies. So it's a mess. And it's hard to predict the future. Yogi Berra said it's really hard to predict the future. Right? Didn't he say? And someone correct me on that quote. I can't remember exactly. You see a fork in the road, take it. I know he said that. Baseball is 90% mental, the other half is physical. Anyway, Yogi, we love you. Even if you have UACR and eGFR, here's the problem. I have a whole slide deck on this. I'm not going to take you through. This was a study we were involved in with one of the biomarker consortia I'm in. Repeat testing, stable outpatient CKD. 4 weeks later, UACR could have gone up, down by 55% or up by 125% and still been within the normal range of fluctuation. eGFR down 16, up 20%, normal variation. We don't have a lot of biopsies in this population, but a recent paper just came out from the UPenn group. This is reference 2. They show the amount of glomerulosclerosis and tubular interstitial fibrosis by level of GFR. And those with normal GFR, you could have 0 to 100%. It's ridiculous how poor that is for capturing what's really going on at the level of the kidney. Part of that is hyperfiltration and DKD. We showed that earlier. Preserves GFR for longer. Then as you age, every year after the age of 30, you lose about 1 milliliter per minute per year of GFR. So by the time you're 70, your GFR is already around 60 just by age. Then you lose a few more nephrons. You have a GFR of 54. Do you really have CKD? Isn't CKD you have to worry about? Then you're limping around because you got your osteoarthritis or your ACL or whatever hurt, and these people are afraid to take an NSAID if they are aware of their CKD because they don't want to affect their kidneys. It's this thing. So who has CKD that matters? And then, as I mentioned, the drugs that reduce progression also drop your GFR. So you got to tell your patient, don't worry, your kidneys are going to get worse and then they're going to get better. And you're not going to explain hyperfiltration necessarily to a patient. And here is the hyperfiltration concept. You're up in this elevated zone. By the time you come back down this curve, you've lost about 50% of functional nephron mass. And then, then the horses start stampeding here. You got albuminuria and dropping GFR. By then it's too late. So how can we improve care? There's about 30 million diabetics, but each year about 50,000 diabetics start dialysis. So that's only a fraction of a percent. So everybody's like, I got time. We'll deal with it in the future because 99% are not going to start dialysis in that next year. And you're already busy enough seeing patients with everything else. Well, I'm cutting a very long story short here on the biomarkers we have been investigating for years now in kidney disease, specifically DKD, some CKD. And to tell you, just the cream of the crop are the TNF receptors, TNFR1 and 2. These are reflecting largely subclinical inflammation, so propensity for fibrosis. R2 is a profibrotic factor when it binds TNF alpha. And KIM1, which is kidney injury molecule 1, reflecting, such a make predictions, especially with the future. Thanks, Matt. Reflecting subclinical tubular injury. And this is a meta-analysis we're doing. I have it here just to show you in comparison to the urine. Took all the last decade of papers. That's really where this data have emerged. The top biomarkers for prediction to at more advanced CKD or ESRD. You can see a lot of urine markers don't have huge effect sizes. These are per doubling or per standard deviation increase in the biomarkers. But TNF receptors and KIM1, most studies and their effect size here is at least a 50% increase per doubling. And TNF receptors give you about a doubling of risk per doubling in concentration. So again, I'm cutting out half an hour of my typical research only talk where we said, let's take now those top 3 biomarkers and see how can we profile an existing DKD population. So we took samples from the Mount Sinai Biomed Biobank and the UPenn Medicine Biobank. They had to have DKD, so they had to have albuminuria if they had GFR above 60. these cells are not really DKD or CKD because their GFR is normal and they have no evidence of kidney damage, or all of stage 3, regardless of albuminuria. We didn't take stage 4 or 5 because you don't need to further risk stratify them. They've reached advanced CKD. But this is the group where 90% of patients with CKD and DKD sit, and a fraction of those are going to progress. So what we did is we measured these biomarkers, we train tested and validated. I'm going to bring you to this slide because this shows you better. We looked at all these potential features: demographics, labs, medications, ICD codes, vital signs, other features. Said, how can we get to this prediction model? And these, we took the best of the bunch, the ones that improved the AUC, and here they are in order of importance: KIM1, ratios of the biomarkers, GFR and UACR, TNFR1, calcium, TNFR2, etc. And what you're really doing is integrating the new biomarkers and domains from relevant pathophysiologic relevance that may contribute to kidney disease progression, and creating this composite risk score for who is going to be at high or low risk for progressive decline in kidney function. We defined, this is more on that validation study, biomarkers measured. Remember, these are linked to the EMR. We had 5 years look forward time after that biomarker measurement, composite outcome of a rapid slope, a 40% sustained decline or kidney failure, 21% overall event rate. And here's the result: improved the AUC by 15%, improved positive predictive value, almost doubled it. Negative predictive value was not worse, and improved reclassification for those who had the outcome by absolute 41%. Relative, it was about a 73% improvement in classification. You can see the risk score here. We scaled it to 100 for motivational factors, so there's a predicted probability underlying it. We said let's scale to 100, so the patient seems activated. Framingham risk, what is it? You can tell someone you have a 21% risk of cardiovascular. The gambler will say I have a 79% risk of not having. Same thing can happen with kidney disease, right? So this way you see 90, 95, 100. They're like, whoa, that's a high risk. And low risk has 10% or lower risk of progression. Here's the Kaplan-Meier. You can see, it's not just, at the end of 5 years you're going to progress. They are progressing throughout this future time period. And we actually did some really cool analyses recently, which I don't show in the slides. That saying, I'm doing a lot of analogies here, or at least similes, but they say, in the stock market, past performance does not guarantee future results. We said, if you know the pre-slope, can you predict the post-slope? There was only 19% concordance on who was progressing before versus who was progressing after. If you just took eGFR, UACR, and eGFR slopes, this is where these biomarkers that have this relevance in their pathophysiology help you improve that prediction. And this is just showing of the patients that reach kidney failure. If you just use KDIGO heat map in that color coding, you only flagged about a third of them. Using the KidneyintelX high risk, 2/3 of those were appropriately flagged. We call this a bioprognostic because you're bringing these biomarkers and prognosticating their risk. You guys know, some of you have been using the test downtown there, and you know that it's commercially available. We have the CLIA certification in all 50 states now, and we are awaiting final clearance from the FDA. The report you see, I hope you guys are seeing the report. If you click on the KidneyintelX specimen result, it has that hyperlink. You will open the PDF report, give you the numerical score, the 3 categorical risk score, low, intermediate, high, and the care pathway that was developed by Mount Sinai population health leaders. That you don't have to go hunting for those ADA or KDIGO guidelines. It's telling you what to do. Heavy dose of SGLT2 inhibitor in the high risk, and consider it for the intermediate risk as well. 62% had a UACR available in this validation study. In that subgroup that did have it, you even improve your negative and positive predictive value. About 45% score low risk. 93% who score low risk have stable kidney function. The feedback when the team calls them, and I'll talk about a care navigation team in a second, they're relieved, they like it, they can continue what they're doing. Annual maintenance of, monitoring kidney function. Those that score high risk, about 15% score high risk, about 7 out of 10 are going to have some degree of progression. And this is to overcome that inertia, trigger that activation energy. The care pathways built in. Titration of ACE/ARB, nephrology referral if indicated for high risk. Act on those, maintain these, monitor these guys like you do clinically. And not only are you getting 7 to 10-fold grading of risk from low risk to high risk, we actually then took that Canvas trial. They had bank samples. We ran KidneyintelX, the biomarkers, generated KidneyintelX score on Canvas population. It completely replicated what we saw in the Sinai and Penn group, and this was 61 countries, Canvas cohort. Those that scored high risk had 3-fold the gradient of benefit in terms of eGFR slope. Again, you're starting with you've got more room because the placebo group and the high risk group are progressing faster, so you can really make a dent on that. And then what we also showed is that from baseline of 1 year, those treated with SGLT2 inhibitors had an improvement in the KidneyintelX risk score, reduced by about 11%. Remember, creatinine's going up at that time, GFR is going down, but the KidneyintelX score, kidney health, improving. And then if your score came down, you had better outcomes than if you had stable or increased scores. And we talked about that, those limitations. Again, I don't have time to show you the data, but actually repeat testing, most patients in the placebo group who don't have progression had stable KidneyintelX scores over time. So you're integrating those 12 inputs. It's more reliable than just having 2 inputs. We're picking up the high risk in these early stages. You're finding those high risk, especially in that stage G3A, where it could be just aging. 70% of G3A is scored low risk. And then those changes in scores are informative in terms of evaluating your treatment response. So the goal is treat earlier. We now have the tools, and this is ironically the intended use for SGLT2 for KidneyintelX dovetails very nicely with where SGLT2 inhibitors and finerenone are indicated. So the goal is, especially, I mean, these are costly drugs. Are we really going to start now triple therapy? Because they all have to have baseline max dose RAS inhibitor. So now you've got to think about 2 other drugs. You can almost titrate your aggressiveness, whether it's talking to the patient about the concerns, getting those prior auths or whatever you need to. This can help you tip the balance. And we're going to be doing a lot more evaluation and validation of this kind of paradigm in prospective studies, looking at how this plays out. Again, it's the way we've launched this at Mount Sinai is not to just put out a test, say good luck. There's been a whole education and awareness of CKD and talks like this and others. There's full investment from population health and internal medicine and Dr. Weissman and other medical directors, department chairs, etc., planning this type of care pathway. There's the care navigation team, which I'll show you in a second. There's central pharmacists that have been hired. The care pathway is embedded. And then I was just showing Dr. Weissman some of the analytic stuff we're now ramping up. And hopefully that can help, again, as reinforcement techniques and improving, again, everyone's internal practices, because there's always room for improvement. And of course, publishing on all this and, leveraging value case-based payment models, which are now becoming more and more prevalent. Martin asked a great question, and Martin's been so key. Great timing, Martin, because Martin was key in especially the CKD guidelines that I'm showing here from the Chronic Condition Management Hub, where KidneyintelX is recommended as part of the risk assessment, along with so much other detail in terms of medication dosing and other management strategies that Martin outlined there. I'm going to answer your question, Martin. It's also in the diabetes care path. So, Martin, the biomarkers came down, TNF receptors and KIM1, which is actually a separate paper that came out in Diabetology from that I'm a middle author on. The Canvas investigators put it out on the 3 biomarkers individually, how they came down with Cana versus placebo. Again, how do you interpret those? Someone who had a reduction in TNFR1, stable R2, KIM1 went up. Again, so taking the integrated score, we think is the way to go. We did just submit an abstract to World Congress in Nephrology a few weeks ago that shows that if you had reductions in the 3 modifiable factors that we know how to control as physicians, blood pressure, A1C, and albuminuria, that those who achieved in the canagliflozin group compared to placebo, they achieved about a 15% reduction in those 3 modifiable risk factors. And those translated into about a 15 to 20% reduction in the composite KidneyintelX score. So that's how you can push. And SGLT2s may be doing above and beyond those individual components. You're actually getting a little UACR reduction, glycemic control, better blood pressure control by like 3 millimeters, and maybe an independent reduction in biomarkers. So that's why we like the composite risk. You don't have to constantly be triangulating everything like Russell Crowe in A Beautiful Mind to figure out where you are with risk. So the way we've launched at Mount Sinai and the way it's launching now at Wake Forest and University of Utah and the VA and other health systems about to come online is that there is a pre-pending by the care navigation team, and that's why you guys are seeing those orders pop in on your eligible patients, so you don't have to think about it. You can decline that order if it's not the right time, they're not getting blood work that day. You get the score back within about a week, and then there's a team now, and there's actually, I should make this plural, central pharmacists that have just joined, and they're going to help. Now you have Priyasha downtown. I think she's helping with getting these patients on the meds. There's embedded pharmacists at some sites across Mount Sinai Health System. Other sites didn't have it. So this central pharmacist team is helping improve the equity across Mount Sinai Health System. There's coordinators, dietitians that are coming on board, Tamara Muller, the APRN, and others, again, to help post-testing with chart reviews, getting those meds on. We have a whole suite of educational materials, not only for CKD actually, but for hypertension, diabetes, etc. Helping make referrals if you need help scheduling those things. And again, the goal is to improve the processes about management and then of course improving clinical outcomes, which will take a longer, it's a sequential, and hopefully this in the next year or two, you'll see the benefits downstream. Just to show you that you're picking up high-risk patients from earlier stages. Here's stages 1 and 2, about 6% and 10%. Stage 3A, 21%. So again, people that didn't look high risk, here's the yellow group. About 11% of yellow here is scoring high risk on KidneyintelX, 20% of orange. So those are the ones. So we think that this, Jennifer, I'll answer your question in a second. We think that this overcomes a lot of the obstacles that were leading to too much kidney failure, like I showed you early on. Lack of awareness, just pre-pending. Lack of risk stratification. We have a robust tool that should be FDA cleared to help risk stratify. The treatment was insufficient. A lot of under-treatment with SGLT2 or max dose or ASP inhibitor, and now finerenone. Again, there's a lot of things both in terms of lifestyle and education and medications here that comes along with the solution of KidneyintelX. And then late referral to nephrologist. Now you're going to be picking up those early patients, and you'll get those monthly reports and feedback to know, making sure that proper management is being conducted. Kidney failure goes away, hopefully, and you can keep patients with stable kidney function for many years. let me, Matt has to go, and Jennifer had a question. So we have coverage determinations with about 17 different pay groups right now. What's important for you to know right now at Mount Sinai is there's no cost to the patient. That you can tell your patients that if it comes up, they will not receive a bill. It is currently covered under contract with Mount Sinai, so you do not have to worry about it. Should anything change with that, everyone will be notified, but it is covered right now. Does it? This is the site where there's been a full ongoing care navigation since about March. And just to show you that, and this is the pattern actually system-wide, the majority are not optimized prior to testing. This, involves max dose Rasenberg and SGLT2. If you're intermediate or high risk. But with this, especially at Dr. Vega's practice, 85th, where they pretty much call everybody, and they had Jackie Mullicari there as the embedded pharmacist. They are taking actions, at least trying to address the meds and make referrals when necessary. These numbers are going to keep changing. The patients who get called find the phone call informative and helpful, the test helpful. They want to be called in the future. 91% want to receive future calls, and 82% are asking for more educational materials. A lot asking about nutrition and diet materials. Oops. And they are, again, there's loads of quotes now, but they are appreciating the calls, and they're motivated to do things, especially when they get intermediate or high risk results. The medical directors are also loving it because it's getting them following the guidelines, getting them on SGLT2 inhibitors. And even nephrologists who, potentially have the least to gain here because, they're already patients in their hands that clearly know they have kidney disease. But they think, again, this low, intermediate, high helps engage them on terms of the awareness and importance of managing their condition and also staying adherent to their medications. Guys, I am going to skip these cases because it's just showing how things got done. But just to summarize here, you got just the orders being prepended, so the test requisition form gets signed. I think there's been about 36 tests ordered at the residence for the residents at GMA thus far. Early stage stratification and support is here. If you need it, you can reach out to me anytime. But really, we've reached the tipping point in the ability to not only prognosticate, but to treat these patients. So don't get left in the dust. Don't you get left in the dust, and don't leave your patients in the dust. Don't let them get to dialysis, or at least say that you tried or had the conversations and they were aware, because it's just too devastating when they reach end-stage kidney disease. So I'll stop there. Jennifer, thanks for the question. And I'll pause. I know we're reaching the top of the hour. Any other last questions? I'll stop sharing so I can see you or hear you.
Thank you, Dr. Coca, for the amazing talk. Any questions from the audience? No. Okay. Yeah.
Thank you, Dr. Coca, so much. This is really interesting application for our patients. I'm wondering if you know or can speak at all to the applicability to type 1 diabetes patients. I know that the studies are probably too small, but do you know if this can be used in type 1 with CKD?
We are not. No, we don't have. We're not approved with the New York State Department of Health for type 1. We did not submit for type 1. There's first of all, after type 1 diabetes, it's like 30 years before you develop nephropathy. The biomarkers, there's been some small biomarker studies that show that they work in type 1 as well, but we didn't have a rich enough biobank to validate the full algorithm for type 1. And really, 98% of that diabetes that contributes to end-stage kidney disease is from type 2. So those are the reasons we do not have for type 1.
Thank you. We are running out of time. Like, if anyone doesn't have additional questions, we would like to stop here and then call it a day.
I'll just say one thing, guys. So I know you started recently using the test. Please, if you have any questions, you need educational materials, anything, any more insight, these dynamic changes I talked about. Our paper just got accepted on the Canvas trial. It's coming out in a few weeks, American Journal of Nephrology. But anyway, I have loads of stuff. Happy to talk to you, get on a Zoom with you, send you things if you're too busy. Whatever it is, just reach out. Again, we think it's the right thing to do for the patients, but any feedback, positive or negative, let me know, let us know. We're here to support you. And again, thanks for your attention and thanks for participating, and really looking forward to, Mount Sinai is really serving as the leader and the beacon for nationwide and potential worldwide on how to get ahead of kidney disease and really reduce this epidemic of kidney failure. So thank you everyone again for your attention.
Thank you. That's great. Thank you. Have a great
Okay.